With antenatal expressing, in our clinic we encourage any lady to actually express their breast milk. Around 36 weeks we can start expressing a little bit of breast milk and we can actually pop that in the freezer. It's generated first by ladies that were diabetic, and they found that they were using a lot of formula with their babies after they were born because their blood sugar levels were low in the baby, and the baby needed extra milk just to sort of keep their sugar levels up. So it was designed to hopefully get the babies to have breast milk first, which is really good for their gut, and any other breast milk that's been frozen we can use from then. It generated from there that basically all our mums, we encourage them if they want to express antenatally, then that's fine to do. Especially the ladies that have got gestational diabetes, have got little babies, or have had previous problems with feeding and had low supply. With breastfeeding, we've got a baby that is coming to your breast after they've been born. Whether it be by a normal delivery, vaginal delivery, or whether it's by Caesarean, we try and do as much skin to skin as possible. So when a baby is skin to skin with you, oxytocin is released, and that will allow that milk to start flowing through your breasts. It's the same oxytocin that you are in labour with that makes your uterus cramp down, and also afterwards when you've had your baby it helps to decrease the size of your uterus as well. So it helps to squirt the milk down through the breast, and the baby takes the colostrum, which is the early milk, first from there. Early and frequent feeds, skin to skin contact in the first couple of days is very, very important. That's always the big question, how do I know if I've had enough milk? There's lots of different ways that you can tell. One is that your baby's going to be satisfied at the end of a feed. They're going to be putting on weight, they're going to have good urine output, and they'll probably have about 2 or 3 poos in a day, and that's quite normal. They can have a lot more poos, and that's still normal as well. We're mainly looking at urine output in a settled baby. What we're looking at is your breasts are feeling quite firm and full at the beginning of the feed, and they're softening during the feed, and it's good for you to be able to feel that and maybe do a bit of hand compressing as well, so that you can actually feel that movement of milk being transitioned to your baby, so you have a bit more of an idea as the volume that they're getting. At the end of the feed, a baby will look contented. They won't be looking around for more. They won't be crying and cranky, licking their lips and searching. They may be crying and cranky because they're tired or a bit of a pain in their tummy, but looking and licking and searching is more likely to be that they're still hungry. Sometimes they will just come off and they'll be very sleepy, and when they are really, really sleepy, you can just pop them down and they may well sleep and settle for about an hour and a half, maybe 2 hours. It's important for them to also feed at night time. That is the best time that you'll get a good feed, and it's a great time to generate your milk supply as well. So that's very important to remember, that your babies do feed, and they feed usually quite well at night time. Even though people don't like the idea of getting up to feed at that time of the night, it is actually the most important time to feed because it generates a bigger prolactin release. So prolactin helps to bring in a lot more milk supply. The signs that your baby has been fed well are they're sleepy at the end of a feed, they're falling off the breast with milk or in their mouth all over their face. They're sleeping well between feeds, somewhere between 1.5 and 2 hours. A good urine output, and at least 6 to 8 to 10 wet nappies a day, that you can actually feel that they're heavy in that spot. And they have about 2 or 3 poos in a day. If you have mastitis, you quite often do feel unwell. You may have a temperature. You may have a red spot on your breast that is creating an inflammation, which is creating the temperature. It may be caused by nipple trauma, where the baby's been on a bit shallow and has damaged your nipple. It might have been bleeding, it might be a scab there, or it might be a bit of a blister there. When you're feeding, sometimes the babies are unhappy because that milk does change to a little bit salty as well. So the best thing we can advise is good attachment will give you a good feed, which will give you a good sound nipples that are comfortable, but also good milk flow, so you're actually moving that milk out. Sometimes stasis of milk can also create mastitis. Ways that we encourage milk supply is obviously skin to skin and unrestricted in the first 2-3 days. We want to make sure the baby's also safe, so if you're having to have a sleep, we do encourage that you don't have your baby with you, and your partner may do skin to skin as well. That skin to skin will help generate that oxytocin surge, which will help to bring in more milk. That is one way. Obviously getting the baby to your breast and attaching well and attaching comfortably is something that's very important, so a nice big open mouth, and it should never be painful with attachment, and your lactation consultants that work here in the hospital can help you with that. The midwife that's looking after you is very, very good at helping you with that as well. So if we have difficulty getting that milk happening and baby attaching, then we'll be hand expressing, and we may use a pump as well. There's also medications that you can take to increase your supply, and that's something that we look at towards the end of your stay. If there's a family history, or if we're feeling that that supply just hasn't quite kicked it up a little bit, depending on what your medical history is like, we may also look at things like Motilium. There's also herbal supplements, and they're what we call galactagogues. They're different foods that you can have that can also be helpful. So they're all part of the little chat that we can have towards the end of your stay. Sometimes there is a fear that you're not going to be able to breastfeed because your family history says that they couldn't breastfeed and neither can you. But we've got to look at each individual, and with each individual there are various reasons why a person hasn't been able to breastfeed, and it might be various circumstances that may happen to your mother that isn't going to happen to you, and you might be very different from your mum as well. There is a certain amount of family history that sometimes there is low supply, but these days there's so many different things that we can do that it makes it so much easier to actually sort of work through and generate that bigger supply for you. So, people like me that's a lactation consultant, your childhood centre that have got lactation consultants, or somebody that might want to come to your home as a lactation consultant as well, can help you through that as well. With gestational diabetes, quite often the mums are a bit worried that they're not going to be able to breastfeed because there's been lots of different stuff in the media in regards to it, and that's where the antenatal expressing is really quite helpful. From about 36 weeks onwards, we can actually look at you expressing antenatally. It's probably not a bad idea to have a little chat to your obstetrician first before you actually go ahead and do that, just to make sure that he's happy and comfortable for you to go ahead and do antenatal expressing. There's been a little bit of literature written about you going into labour if you start hand expressing at about 36 weeks, but there's been proof by the DAME study that the oxytocin release that helps move the milk down when you're expressing is only quite small, and it's not something that would put you into labour. It just helps to boost up your supply, get that going. It might come in a little bit earlier, because sometimes with gestational diabetes it's a little bit slow coming in, just because there are different hormones that are a little bit higher than just a person that doesn't have gestational diabetes. And that just helps to bring in that milk supply a little bit quicker. Skin to skin is really important, and just looking at having that supply there for your baby if they do need to have a little bit of time in special care, because sometimes their blood sugars are a little bit low after they've delivered. So how is milk made? Milk's made by obviously you falling pregnant, and somewhere around the 14th, 16th week you can actually produce colostrum. You'll notice the first couple of trimesters your breasts have grown in size. Sometimes it's a couple of cup sizes, and so that gives you a fairly good idea that you're getting some breast tissue growth, and when you get that breast tissue growth, then you'll find that when you get to the point of feeding, there'll probably be some colostrum there. You might even find at term you're a bit crusty around the nipple, and that's probably the colostrum that's coming out. With the exposure of the baby being on the breast within the first couple of hours, whether it be skin to skin or whether they're actually breastfeeding, will also help with the oxytocin release, which is the release of hormones that may put you into labour, but it also squirts the milk down the breast and allows them to feed from the breast from that oxytocin release. So when we have that oxytocin release, it also cramps your uterus down, so your tummy goes down. So it's all quite beneficial with the breastfeeding. So that's the beginning of your breastfeeding, and it can take a full 6 weeks to fully have that milk coming in and being generated. And it's the fact that you're feeding frequently in the first couple of days, unrestricted, skin to skin as much as possible. It doesn't have to be 24/7, but when we're actually looking at breastfeeding unrestricted for the first few days will make a big difference to what your supply is like. And as you're going home, that's starting to generate. It may be in or it may not be in, and that's quite normal. When we get to the point of going home, you'll find that there'll be people there to help you with that as well. Within the first 6 weeks it does change a lot, so it doesn't mean that if your milk's not in when you first go home that it's never going to come in. There's lots of different things that we can do to help you with that as well. So with the caesarean section, a lot of our caesareans are elective. Some are emergency, but most are elective, and a lot of ladies worry that they're not going to have a good supply because they haven't been in labour, which can help to initiate that an early part of breast milk production. But what we will do is try and do your baby skin to skin as soon as that baby is delivered, or soon after, as long as the baby's condition is okay. In the theatre we can do skin to skin. In the recovery ward we can do skin to skin as well, so that we encourage you to do that again for the first couple of days, as well as unrestricted as much as we can. So on discharge, we always give mums a plan if there's a problem with their feeding, whether it be attaching, whether it's low supply, or the baby's just sleepy sometimes as well. We'll give you a plan so that you know what you're doing when you go home, so that we can actually help you through those first few days when you're at home. Once you get home, it's also, you've got your early childhood centre that you can also see. We also have our helping hand clinic here that you can make an appointment and come back and see us and utilise that plan up until that point. Then we can reattach the baby to the breast if the baby's not breastfeeding or supply is still low. There's a lot of different avenues that we can look at in regards to getting that supply up. So you'll always go home with a plan. So 6 weeks from birth it can take for your milk supply to come in. Quite often ladies do come to see me in the clinic, and they may come and see me in the antenatal clinic as part of our Helping Hands clinic, just to talk about how I can do things a little bit better this time. Quite often the breast will naturally start to grow more breast tissue with each pregnancy, so quite often the first pregnancy with poor supply or difficulty feeding doesn't always occur with the second pregnancy, and it also depends on each individual baby and situation as well. So when we know that you've had difficulty in the past, we'll also make sure that we get to see you nice and early so that we can get your baby feeding and doing skin to skin. And it'd be like every other lady that's having a birth at our hospital. We'll encourage that skin to skin, but just keep a really close eye on it. And you'll also be a little bit more conscious of it as well.